Good day, Dr. Blake. My name is Audrey Andino, Audreyandino. I'm going to do a 360 scan of my environment. Vital signs have been taken. Heart rate is 105 beats per minute, which is abnormal and indicates patient is in pain, stressed, or cardiac compromise. Blood pressure is 167 over 100, which is abnormal and indicates hypertension. Heart respiratory rate is borderline normal at 20 breaths per minute, which indicates patient is uncomfortable or anxious. I'll continue to monitor vital signs. MRP has been paid for further evaluation of patients. Now I'm going to proceed to do cardiac assessment. On inspection, patient appears fatigued and uncomfortable. Is restless but is able to communicate in full sentences, no dyspnea noted. Skin color is a natural tone and consistent with ethnicity, no pallor or cyanosis noted. No visible abnormal pulsations noted, and no jugular vein distension. Now I'm going to palpate pulses. I'll perform hand hygiene, and I'll start with the carotid pulse one at a time. It's regular and slightly rapid. I'll do the brachial pulse simultaneously. Regular, slightly rapid, and equal bilaterally. Do the radial pulse, slightly rapid, regular, and equal bilaterally. Then I'll do cap refill on fingernail, which is less than 3 seconds and within normal limits. Check the dorsalis pedis pulse is regular, slightly rapid, and equal bilaterally, which indicates accurate peripheral perfusion. Do the toe capillary refill on the toes is less than 3 seconds and is within the normal limits. Now I'm going to proceed to auscultate the heart sounds, and I'll be using the diaphragm of my stethoscope to listen to the S1, listen for S1, S2, and murmurs. I'll start with from the right side of the chest, second intercostal space, which is the aortic valve area. S2 is heard the loudest. I'll move to the pulmonic valve area on the second intercostal space of the left side. S2 is heard the loudest. I'll check the third intercostal space of the left side, which is the Eps point. S1 and S2 are equal. Move to the fifth intercostal space, which is the tricuspid valve area. S1 is heard the loudest. Then I'll move to the mid-clavicular line of the mitral, which is of the fifth intercostal space, which is the mitral valve area. S1 is heard the loudest. I'll also use my bell to listen for low-pitched sounds such as murmurs S3 and S4. Aortic valve area, pulmonic valve area, Eps point, tricuspid valve area, and the mitral valve area. A murmur is a sound. A murmur is a sound that is a gentle swishing sound. And I'll use the diaphragm of my stethoscope to listen to the apical pulse at the mitral valve area for 1 full minute for the rate and rhythm. The rate is 105 beats per minute and the rhythm is regular. I'll proceed to do an Abdo assessment on my patient. The abdomen is a natural tone, and there's no jaundice or bruising noted. It's the skin there is intact. There are no rashes, lesions, or striae noted. The abdomen is symmetrical, no lumps, masses, or bulging, and the umbilicus is midline. The abdomen is soft, slightly rounded, and there's no distension. Now I'll proceed to auscultate for bowel sounds, and I'll be doing this before percussion in order not to alter the bowel sounds. Normal bowel sounds heard in 5 to 15 seconds are expected. I'll be doing this using the diaphragm of my stethoscope, and I'll start at the right lower quadrant, which is the appendix. Active bowel sounds are heard. I'll move on to the right upper quadrant, which is gallbladder and liver. Normal bowel sounds are present. Move on to the the left upper quadrant, which is the stomach and the spleen. Active bowel sounds are heard, and I'll move on to the left lower quadrant, which is the descending colon. Normal bowel sounds are present. I would proceed to percuss the abdomen using the middle finger of my my dominant hand, tapping on the middle finger of my left of my non-dominant hand, and I expect to hear tympany over bowel filled areas and dullness over solid organs. I'll start at the right lower quadrant, which is the quadrant farthest from where the epigastric pain is. Right upper quadrant. Okay, now I'll be palpating the patient's abdomen using 3 or 4 fingers, depressing 1 to 2 centimeters into the skin in a gentle circular motion. I'll be observing, I'll start at the right lower quadrant, which is farthest from the epigastric pain. And I'll be observing for facial expressions such as signs of grimacing discomfort. And I'll also be assessing for masses, tenderness, and guarding. Tenderness is, there's tenderness in the epigastric area, which is where the patient feels the pain. S-bar. Good day, doctor. I'm calling from the ED. My name is Audrey Andino, and I have a patient, a 63-year-old patient who presented to the ED today with chest pain and epigastric pain rated 8/10. The pain is radiating, occasionally radiates to the lower arm, reports nausea and 1 episode of vomiting before arrival. His vital signs are 105, heart rate is 105 beats per minute, and blood pressure is 167/100. Respiratory rate is 20 breaths per minute. Patient is has history of hypertension and type 2 diabetes, S1 and S2 heard, and then there's tenderness felt in the epigastric area. I recommend you come and evaluate the patient further and put in orders for cardiac monitoring. I think that the patient is experiencing an acute coronary syndrome or MI. As a nurse, I'm going to make sure there's an IV access for emergency treatment, as well as continue to do pain assessment on this patient. I expect that the physician will put in an order for ECG, as well as cardiac biomarkers for troponin levels. Thank you. Ha!